What were you saying?
She's
mezcal?
like, look, tequila, and let's go.
It's a different kind of cementoplasty.
So it's a different kind of anesthesia.
All right, welcome back to the Ouchcast. My name's Neal, Rakesh, and I'm with my co-host today, Dr. Gulati.
Half the time I'm a co-host, half the time I'm not a participant.
You're ambiguous.
No, we don't go that right.
And today we're talking about cementoplasties.
You know, it's a really interesting topic, especially when it comes to cancer pain medicine, when to apply augmentation procedures like cementoplasty, when to put it in context of surgical and radiation and some of these other therapies that we have to help control disease in the spine. A lot of confusion, and I think hopefully today we get to clear some of this up.
I understood a few of those words, but I have a feeling we're going to learn a lot more as we go through this. Who have you got for us today?
First, we get the Webster's Dictionary out. We'll figure out some of the words I said. And after that, two of my dearest friends, Carolina, who has been a wonderful mentor, physician. We've been exchanging many ideas from Mexico or Mexico. I'm not exactly
Mexico.
sure.
Oh, here we go.
And there we go.
Here we go.
And at the Cancer Institute there in Mexico has done a wonderful job really treating a lot of patients. And I think her expertise would be very vital to this conversation.
Yeah.
And then on Dr. Motivala, neurosurgeon extraordinaire, who really can give us insight on how we can kind of combine some of the things that pain medicine does and put it in context of when are we supposed to actually intervene, as opposed to a pain doctor doesn't really know what to do or where to direct the care. In reality, I think our neurosurgeons, probably our radiation oncologists, are really spearheading the decision making, and we should have that as part of the continuum of care discussion.
Thank you so much for having us.
Yeah, thank you for stopping by. Let's talk about the simple thing. What exactly is cementoplasties? What does that mean when we say that?
It's CC, injecting bone cement, under CT or X-ray guidance. That is
Okay.
osteoplasty. Yeah, it's the art of injecting bone cement.
That sounds pretty interesting. Why would we ever do this? Why do we want to inject cement into people?
You know, it's used for a number of pathologies and in a number of ways. For Carolina, it is used for, compression fractures due to cancers, where a cancer has invaded and weakened the bone. And those fractures, while they may not be unstable or dangerous, are incredibly painful for these patients, incredibly painful. I mean, these patients can't get out of bed, they can't move. And with her artful cementing in the bone, she's able to, really, really, really help their quality of life. And that is one of the reasons. Other reasons are osteoporotic compression fractures, so non-cancer fractures of these bones. Again, these aren't unstable fractures. Mm-hmm. You're not worried about the spine falling apart. But even though it's not dangerous, it's, again, incredibly painful. The mechanism is incredibly painful. And you are able to really shorten the duration of their severe pain, allow for them to get up and moving faster. And as physicians, we all know, especially elderly, sick, infirm patients, they really need to get out of bed. If they don't get out of bed, they end up with all kinds of other problems,
Where do you see these compression fractures? I know in osteoporotic fractures, we're always talking about the lumbar spine usually. But in cancer, are you seeing them everywhere? Or?
Yeah, we see those fractures everywhere, even in long bones. And the most important thing we do is to correct the instability, spinal instability, or even pelvis instability. The main purpose is that stability. And when it comes with cervical and thoracic, the main point is the guidance you use. Yeah. Now we have, fortunately, hybrid procedures, CT and fluoro, that change everything in terms of security for cervical and upper thoracic levels. Yeah. And also sacrum, because every sacrum is different.
You said the keyword stability. Mm-hmm. How does someone out there realize their patient is stable or unstable, right? People may not even know what that means in terms
like
of
a Sesame Street word, the key word.
I think it's important, right? That distinction of what, like, how to, it may not be pain necessarily. It sounds like it might be the stability of a patient. There's some key things that we can track with a patient.
The key thing that you want to look at is the spine going to fall apart and compress the neural elements, the nerves, the spinal cord, right? And give a spinal cord injury. That's what we truly mean when we talk about stability. We're not, small micro drifts, like slow collapse.
Yeah.
It's okay. But what we're really worried about is something acute causing an acute compression of the spinal cord and nerves. And that's what we're trying to prevent so that we can keep these people neurologically healthy and then also provide them with pain control. And so there's two parts to that.
Can they get out of bed, like, if you're unstable? Like, is there some easy things for us to know?
If you're a truly unstable fracture, meaning that there's hypermobility between the bones, where if they move themselves, there's a danger of things flexing or bending to the point of compressing their spinal cord, the answer is no. You need to do something to stabilize that patient before they get up. Most of compression fractures, are pain generators. They may cause some deformity, but they're not unstable to the point where it's dangerous to the health of the spinal cord.
Yeah.
But cancer is a little tricky.
Yeah, Carolina, what about cancer patients? Anything different about those fractures that you worry about? Or maybe even impending fractures? When do you decide?
That's the main point, impending fracture. And we have in cancer patients several scores and several scales. One for instability of the spine that takes into account pain, the location of the vertebral bodies, etc. Other can be used for long bone tumoral activity, like Tomita scale, the modified. It takes into account how many visceral metastases and the prognostic the patient have, how long the patient will live, and how invasive we can be with them. So many percutaneous devices, not only bone augmentation, even screws and bone augmentation can
you
work.
Often work together, it sounds like, if you had to, like, screws and cement.
It is, we actually, in the last several years, for patients with poor bone quality, and certainly cancer patients count as having poor bone quality for myriad factors, that we now have these wonderful fenestrated screws that we actually inject cement through the screw and intercalates through the screw into the bone.
Oh, that's awesome.
And it helps the screw stay seated in bone that would otherwise be too weak to hold the screw, and you would end up in hardware failure. And certainly you don't want to take these very sick patients to the operating room one time, let alone for revisions. And that really has helped with this particular subset of patients.
I need that stuff to go through my drywall.
I have a stupid question. When would you choose, like, you obviously have these fractures. You have compression fractures, osteoporotic fractures. When would you choose to use some kind of rod or something where you're essentially fusing the two ends together versus you'd use cementoplasty? Is there a certain instance where you'd use one versus the other?
Again, it comes back to this idea of instability or impending instability. Actually, Carolina brought up a point. Sometimes we see a patient who has a tumor in the bone and it hasn't collapsed yet. She brought this up. But we know they're going to need various treatments that will weaken the bone, melt the lesion, and weaken the bone further, radiation treatment. Yeah. And so when we get together, and usually this is the collaborative nature, we sit in a room together, surgeon, interventional pain management, radiology, we sit together, tumor board. Yeah. And we sit and we talk and we say, well, this patient needs radiation. We think this bone's going to become unstable. At that point, we would make a decision based on the tumor, the anatomy. Are we going to have a minimally invasive approach by cementing it up front? Or does it need something more than that? Does it need a vertebral body? We remove the whole vertebra and we have to put a column of support, a metal column of support, plates and screws. And those are the conversations that we have.
Carolina, how do you work with your oncologist? Because from an oncologist perspective, they're probably not thinking what cement is. They're probably not thinking about rods. What do you tell them? How do you work with the oncologist to say, these are the things that you need, and maybe not just radiation? It's
easy when in terms of outcomes of the patients. Even patients come and say, "Oh, I want bone augmentation as my friend who has the same type of cancer." So they see the results, and I have an interesting story about when I was a fellow. I always see in a wheelchair a patient with multiple myeloma. We started augmentating her vertebral body, and first we performed a femoroplasty, and she always bring us some cake, right? So that's why I remember the patient.
So that's why you do these, just to get cake. Only doing it for the cake.
Delicious. Yeah. But one day she came to the office, and I was typing down, and I saw the cake, but the cake wasn't in the wheelchair. The patient was walking with the cake.
Oh wow!
So yeah, that's how good bone augmentation could work, especially in the setting of multiple myeloma, because it is known that every month a patient with multiple myeloma will lose 1 millimeter of vertebral body. That has been studied prospectively.
Just to kind of be more specific, when you're talking about augmentation, so we said cementoplasties as kind of like a general term. So cementoplasties being we could put cement into long bones. There's also putting cement into the vertebral body. So I think classically we call them either kyphoplasties, vertebroplasties. Are there any other like things that would classify under cementoplasties, or did I get all of it?
Or plasties? Along those lines.
was that a dad joke? Yes. Get plastered at a bar. Was that really?
I've read about the sternum and costal.
Yeah.
That is
an important distinction though is vertebroplasty and kyphoplasty. Do you have a preference in many situations of one or the other, or do you strictly do one? What is kyphoplasty versus vertebroplasty? People may not even know that.
Yeah, in kyphoplasty, you introduce a balloon and create a cavity, and apparently the risks of leakage of bone cement is less. It's mainly because of costs. No trial in cancer has been performed comparing one over another. Yeah, it's mainly in Mexico. It's because of money. Money issue. Yeah.
Okay.
Do you largely perform the vertebroplasty then in that the balloonless fill of the bone then?
Yeah.
How do you control the flow? Here, I see people make roads with cement, and I'm a little afraid.
A lot of X-ray, applying it in fluoroscopy guidance continuously.
So imaging, like we mentioned before, is critical to success.
Yeah,
and also to prevent some of these side effects that might occur because of the spread of cement into other locations, spinal cord, lung.
But in the recent years, we have found that even what was a contraindication, loss of the posterior wall of the vertebral body, was a contraindication not to perform because of the risk of leakage into the spinal cord. But now it's not, and I'm performing those.
We need your data.
Yeah. Well, no.
In the literature.
Asiatic started that. And maybe in some palliative care context, some patients really need that.
That's interesting. I was going to say on that topic, what are the reasons why you can't do this? Like, are there specific things? Because sometimes this sounds like it's an emergency. It's like if someone's impending collapse or there's something that's going on, are there reasons you can't do a cementoplasty? Like, is it, I mean, do you worry about anticoagulation? Like, is is that not as big of an issue?
We love the surgeon's response.
What is anticoagulation?
I have removed too much from the spinal cord.
There's the answer is complicated, right?
Yes.
Because on label, certainly if you have a patient who's on Coumadin that you can't take off, you're taking a risk if you assume doing this. But what we found is, and the cement is going to stop the bleeding. It tamponades the bleeding. It's hot. It tamponades it. So again, there are patients where this is truly palliative, right? And you have to weigh the risk with the fact that this person is in unending, desperate pain that you honestly oftentimes cannot fix with IV narcotics, with fentanyl patches. It doesn't work. And so I think that you have to think about it, but we have done it in the past, and we've been successful with it.
Have you done cervical spine?
Under CT guidance.
That's
That's great.
That's some brave. That's amazing. That's, I've heard of people doing it, and now I'm sitting beside someone. I have a lot of respect for that.
That's my favorite part. Every time I talk to you, I realize, and I was like, whoa, that's what you do. That's so cool.
Yeah, actually, Dr. Plancarte is the bravest. So he started, and then
he's been described as a godfather to me every time he describes him.
We all know Dr. Plancarte. We had to bring him on Ouchcast one day.
Yeah, it's sometime in the future. It's the wish list.
Is there some criteria you can give us, Dr. Motivala, just like of something that tells us like when to, as a pain physician, when do we have you come in involved? Like, is there something that can guide us to say we should do cementoplasty? We should really, really think about surgical involvement, or should every patient with metastases go to a surgical and radiation evaluation before we even consider?
I think it's always better when we work together, right? I really do think it's always better. I do think these patients should get, radiation oncology consult, medical oncology consult, an interventional pain consult, and a surgical consult. And then that's when we have that group think about what is the best course of treatment. Because we don't just have to take into account the anatomy, where the lesions are, how many, but also the lifespan of the patient, right? Mm-hmm. What is their longevity going to be? If someone, we think that they're not going to survive 3, 4, 5 months, to put them through a large fusion decompression surgery, may not be the best thing. And if there's an alternative to just palliate them, maybe not make them perfect, but palliate them, then I think that should be in the discussion. Because at the end of the day, these are people we're treating, not scans, not CTs, not MRIs. These are people. And we have to make the best decision for the person. But certainly, obviously, I think everyone here knows, if you have a patient who comes in with neurologic deficit from cord compression, that's a surgical consult.
Yeah.
That one's easy.
Yeah, I'm not able to.
It should be easy.
I don't think epidurals are fixing that.
No, should be easy. No, we've all seen patients delay visit to the ER, try different injections, and it turns out they have a losing function of their lung or their bladder or something. So we see all these things. Probably you say the same thing in Mexico. They probably come late to you sometimes.
Yeah. But I think that's an important concept. What you're saying is that can you do it? Yes, you can do any of these things on the patient, but I like that thought. Everyone gets together and you say, these are the things that we have. What can we do? And then what does the patient want? Like, is this the right scenario? Oftentimes you have these discussions about pumps, kyphoplasties, and various other things. Is this what the patient wants, and does it work for their scenario of what they're going through?
I had a future question for you, Carolina. Where do anything you're working on that's novel or new in this space of cementoplasty that you can enlighten us with and kind of educate the rest of us?
Not working directly, but reading something that's bone cement carriers, right? Of chemotherapy, radionuclear therapy. That would be
to maintain the control of disease after you perform the kyphoplasty, if radiation is not successful or something.
Yeah. And even I don't know, nano
therapies.
Therapies, that would be.
Means really small.
We're trying to publish.
I wasn't sure if you were trying to say Spanish at first.
No, it's probably Latin. Or Greek.
Just trying your Spanish again.
Good.
What about radiation? Is there anything? I mean, we've talked about like if there's something that's going on, a lesion within the bone. Do you ever say that radiation may be something that may be more amenable in that case?
There's no published data. What we do in our experience, because there's no committees saying what to do, first radiation or augmentation. But usually we radiate the patient first, and then we inject the cement.
Gotcha.
Just in some few cases when there is the impending fracture, severe pain, and sometimes the radiologist cannot get to the point or make an appointment in Mexico because of some traumas, we have performed augmentation before radiotherapy. But it's technically it's much more difficult because it's very, very. It doesn't feel like cement. It just feels like something very soft.
I always say the bone feels like wet croutons when it's in this. It's like it's like pushing like a metal pipe through wet croutons.
Oh, that's interesting.
I mean, I'm a very tiny lady. for some of you who can see. I'm pretty short. I have big heels on today. And, the fact that sometimes I'm just freehanding right through the bone with one hand, that's how soft this bone can get.
Yeah.
Are there any controversies in deciding fusion versus augmentation in neurosurgery? Like anything is everyone going to make the same decision? Neurosurgeons, spine surgeons, we certainly have a maximalist wing. And, there's data like we have to take out the entire vertebral body. We'll put a cage. We'll put screws, three up, 3 down. And sometimes I think, this is anecdotal, right? We have some data for it. Dr. Bilski, who you work with, he has published a lot on this and his opinions. But again, I think you have to look at the human being, right? I mean, to have some progressive kyphosis that isn't going to cause you neurologic deficit over, when you don't have a long life expectancy given your cancer, again, why are you going to put someone through that? And if we can if Carolina can come in and put some cement in a procedure that takes probably for her 20 minutes, without heavy anesthesia, sometimes just with local, 20 minutes.
just with local, with minimal recovery time. And so that they can go on and get other treatments quickly. Remember, when we do big incisions and a patient then needs radiation, we have to delay that radiation so they can heal. Yeah. So, also it gets them to treatment.
From they might be in the chemotherapy regimen, the recovery.
That's a great point.
Compromise, they get infections. So again, look at the human. What are we trying to accomplish? And
that's a great take-home point.
And I think that's, sometimes we get so caught up in algorithms that we forget that these are people.
Or forget this is Ouchcast.
This is the ouch boards now.
The ouch boards.
The ouch boards. The ouch cancer boards.
You can go on and on and on.
Yeah.
I think this is how we should do all tumor boards.
It would be very much easier, right? It's just.
It'd be very. I'm not sure it would be accomplished, but
it'd definitely be more fun.
Yeah, this is it's been pretty awesome. Is there anything else that you see? Like you were talking about a lot of larger surgical procedures as a larger incision. Do you see that there's future things in the surgical world that may make that where you're able to do these things a little bit easier while you're doing something concurrently, like you're doing radiation, or is it always going to have that limitation surgically?
Again, it's we have made things smaller. We have minimally invasive percutaneous screw placement that we do. Now enabled, with the cement technologies, it really, because, these patients may not live long enough to fuse, right? Sometimes. So, now you can augment the screws with the cement, which certainly helps. Even things within the cementoplasty space, they now have stents that they can put in the bone to provide a little more support.
Right.
They have trade names and things like that, but they essentially, go into the bone, expand up like rebar. And then you throw the cement in. And some people have found they've gotten even more correction and prevention of, kyphosis and deformity with those. So all of those things take us that much closer to us being able to affect real change for these people in a minimal way.
Wow. Carolina, can we come learn with you? Can someone can you come learn and observe?
I want to come see this.
I just want to go to Mexico.
CT guided. I actually really want to come see the CT guided cervical cementoplasty.
You do some
very
good work there. So
that's really
We'll wait for you with tequila, of course.
Hopefully not while it's happening.
What were you saying?
She's like, look, tequila, and let's go.
It's a different kind of cementoplasty.
It's a different kind of anesthesia.
Yes.